My name is Patrick McCartney. I'm the Executive Director of the International Essential Tremor Foundation. We want to welcome you to the IETF webinar and thank you for joining us today. Today's topic is essential tremor diagnostic process and treatment options. And our speaker today is known to his patients and his colleagues as Dr. K. Dr. K completed his internship in internal medicine, residency in adult neurology, and a fellowship in movement disorders at the University of Texas Southwestern Medical Center in Dallas. He is a member of the American Academy of Neurology and holds board certification from the American Board of Psychiatry and Neurology. Dr. K is also is assistant professor of neurology at the University of Oklahoma Health Sciences Center in Oklahoma City and is the director of the OU Parkinson's Disease and Movement Disorders Center. He has received several teaching awards and is frequently invited to speak for CME programs. Focused on community medicine, he has developed clinics for the uninsured in tandem with the patient support groups to improve statewide access to movement disorder specialists, as well as access to research studies. So let's go over the format for today for just a few minutes. Second here, Dr. K is going to speak for approximately 30 to 45 minutes. Then we're going to spend the rest of our time answering questions. So to answer or to ask a question of Dr. K, up at the top of your screen, the second button from the right looks like a little bubble. When you click on that, you'll see a drop-down menu. You want to click on the @ symbol there and then click on Dr. K's name and type in your question, and it'll go directly to Dr. K for him to be able to answer your question. So I'm going to now try to share my screen with Dr. K so he can get started with our program. Share mouse, pass presenter role.
Need help?
No, I said I'm passing it to him right now.
Okay. So everyone can figure it out. Just figure it out.
All right. So thank you so much, Patrick. Just to clarify that I'm loud and clear, Patrick, could you send me a message back if you can hear me and you can see my screen? Well, super. Well, thank you so much, everybody, for joining in today. I think we'll keep it short and simple. As you can see right here, a pretty quick introduction to essential tremor is what we're going to focus on today, with some of the treatment options available and what it is that we need to distinguish essential tremor from Parkinson's disease. Give me 1 second. I'm going to click and move some of these buttons out of the way. All right, here you go. Well, this is a quick bio summary of, and that's how I look like on a good day. I run the movement disorders division, so meaning we are a tertiary referral center for essential tremor, Parkinson's disease, dystonia, anything to do with funky movements. And we offer some of the more advanced therapies, which many times involves deep brain stimulation, ablative procedures, Botox injections, etc. And some of which we will actually delve into today as well. This is my disclosure slide. And our learning objectives. And kind of what I just mentioned a little while ago, understanding the basics of essential tremor, the disease and its symptoms. How do we differentiate it from Parkinson's disease and other tremor disorders? And learn about the different options available. Hold on, I'm just going to allow, I guess it's me who has to keep allowing more and more folks to join in. Some folks are joining in right now. Give me 1 second, let me just add all of them. There we go, perfect. All right, so before we get into essential tremor, what exactly is a tremor from a movement disorder standpoint? You can see what it is in terms of definition. It's a rhythmic involuntary movement which looks like a rapid oscillation of a body part. Typically, your fingers or your wrist or your whole limb itself will oscillate or move. Similarly, your head, your tongue, your chin, even your vocal cords can have this kind of oscillatory, rhythmic, involuntary movement. There are different kinds of tremor. There's a resting tremor, and this is the kind of tremor when your limb is at rest. You're sitting there with your arms relaxed by the side watching TV, and you notice that your fingers or your wrist is gradually moving back and forth in an oscillatory manner. That's a resting tremor. The second one is a postural tremor. This is the kind of tremor which occurs when your limb is held in a particular posture. What that means is, for example, you're holding your cell phone next to your ear and you're talking to someone. In a few seconds, you start to notice that your cell phone's shaking because your whole arm, as you bring it close to your ear, is shaking as it's kept in that posture. Or, for example, you're driving and you've kept your arm on the steering wheel. You notice after a while that the arm starts to shake as it's kept steady on the steering wheel. The third kind is action tremor. This is the kind of tremor which occurs when the limb is in motion as you try to move your arm. For example, you lift a cup of coffee from the table and you bring it to your mouth. Your hand shakes or tremors throughout that motion as you bring it from the table all the way close to your mouth. That's called an action tremor. Essential tremor is a tremor disorder comprising of both action and postural tremor, typically affecting both sides of the body, usually in your hands, in your arms, gradually affecting your head, your voice, sometimes even legs. It's a very common neurological disease. In fact, it's the most common movement disorder, 10 times more common than Parkinson's disease. So if you do have a tremor, the odds are that you most likely have essential tremor and not Parkinson's disease. This can occur at any age group, but the typical mean age group for this to occur is roughly in your 30s and 40s. This gradually starts to build up and it progresses over years, over decades. It takes a long time for this to gradually evolve and manifest to different body parts. It usually worsens with caffeine or caffeinated products, and many times than not, it improves with alcoholic beverages. We don't really understand what causes essential tremor. There's not been a conclusive cause or damage noted in the brain, but we have some scientific evidence that it's probably starting or affecting a particular part of the brain called the cerebellum and its connected nerves. Cerebellum is a part of the brain which is on the back side of your head, close to where the nape is, and this structure is what is involved in balance. It's your major balance organ in the brain. We think a dysfunction starting here is what kickstarts the tremor. We know there is a high genetic predisposition because family history is very commonly seen. You almost inevitably will have a father or mother who has similar symptoms, their siblings, some of them will have it, a grandparent who has it, and so on and so forth. There's about a 50% chance of inheriting the disorder. For each child that you have, they have a 50% chance of inheriting the disorder. The funny thing about it is that not everybody gets it in the same pattern. For example, you might have a brother who has a lot of tremor in his hands and you have very minimal tremor in your hands. Or your father has it more in his head and his voice and you have it more in your hands. So there's a lot of variability as to how you manifest or the extent of tremor that manifests in you. In terms of true genetics, there are several genes being implicated. One of the more bigger ones which has been studied has been LINGO 1 and 2 gene in essential tremor.
Then it went to the red.
And over the years, has it been a gradual worsening, or it was a sudden worsening from the very beginning itself?
It's been gradual.
Does this run in your family?
Yeah.
Who has it?
I have two sisters that have this, the exact same thing, where it started gradually for them, and it's become worse. One sister has it, and hers started out bad, and it still is bad.
And how about your parents or your grandparents?
Oh yes, my mom did have it too.
Okay. Does it run in her side of the family?
I don't know.
Well, as you can see right there, that's a classic example of a patient who comes into our clinic who gives you this long-standing story of tremors, gradually worsening over the years with a strong, nice family history. And you're going to see more and more of the interview and the history taking for this very patient as we move along in this lecture. And the reason I put these videos up there is just so that you get a flavor of what it is that we're asking for in our clinic visits with you. And this is something which you need to expect your physicians, whoever you go and see for an evaluation of your tremors. These should be the kind of things they're asking, they're looking for, they're making sure certain mimics are not happening as well. For the most part, the history itself provided by the patient will give us a pretty clear-cut idea of what is happening. So when they tell you that this is going on over years, it's mostly seen with action, or when she sustains a posture with her limbs, we kind of know this is most likely essential tremor. And then you solidify the diagnosis with a clinical exam. The way we usually test our patients include we bring their arms out in different positions. We try to bring out the tremor because certain positions will bring the tremor out much more evidently. We make them do certain things to bring out the tremor as well. We try to make them write, which you will start to see they'll have a scratchy handwriting. We make them draw spirals so that the spiral becomes real scratchy and tremulous as they start to draw out the spiral, or even make them drink from a cup. And we look and see if they're starting to spill water from a cup. Let's see how she did. Could you hold up? And this is a postural tremor that we're trying to ascertain right here. She's sustaining a posture, and you can see how her hand starts to tremor. There it becomes more evident as she flips her arm around. Sometimes tremors are more evident as you get closer to your head or to your face. And this is to assess the action tremor. As she moves her arm with action, is there a tremor? And you can see right there, it trembles as she moves from one point to the other. This is where we're looking for the resting tremor. You're sitting still, watching TV, does it shake at all?
No.
Okay.
My legs do.
From time to time?
Yeah.
Okay. Very good. Now, I would like you to hold the note for as long as you can after taking a deep breath. E would be not too bad, actually. All right. How about we draw some spirals and give me a sample of your handwriting? Okay. So you can see right there, her voice is not very tremulous, and that's how we test it typically, trying to make them hold a note. So there's a 7-day note in your regular cursive hand.
I practiced writing.
Very good. Could you go ahead and draw me a spiral, starting in the middle and working your way out? Starts to get tremulous as she goes from the inside out. Very good. Now, use the other sheet of paper and try it with your right hand. Not too bad with this hand. Very good. Now come over and take that glass of water which is filled and try to take a sip with each hand. Okay, now try it with this one. You can see it's more obvious tremor on that side with spillage as well. As part of our exam and history taking, we always look for mimics, which can cause similar tremulousness in patients. For example, if you have diabetes and you have high or low sugars, often with your diabetes, you can get a similar tremulousness in your hands. If your thyroid is functioning way too high or hyperthyroid, you can have a similar fine tremor in your hands as well. Several medications can induce or worsen tremors as well. For example, inhalers, like you take for your asthma or your COPD, these can provoke tremors. A lot of your mood medications or medications which you take for psychosis will activate or induce tremors as well. Many times brain damage from either trauma or from diseases like MS, multiple sclerosis, can induce tremors. So which is why it's always crucial to get an MRI of your brain as part of evaluation. We also screen for neuropathy, which is nerve damage in your limbs. And if these neuropathy is pretty severe, you can actually get a subtle tremor. Dystonia, which is an abnormal posturing of a body part whereby certain muscle groups go bad and they pull that joint out of alignment. This particular condition can also mimic a tremor because the good muscles are pulling it back into neutral position while the bad guys are pulling it back out of alignment. This back and forth action can also mimic a tremor. But the big thing we worry about is Parkinson's disease. And what we do as part of our exam is to look and see if they have other constellations of features which are consistent with Parkinson's disease. And you can see right here some of the signs which we see with Parkinson's. First off, their tremor is a resting tremor, unlike an action or postural tremor you saw in the patient in the previous slide. They have a slow resting tremor, usually on one side of their body, gradually spreading to the other side over the course of several years. They have slowness and stiffness, both on exam, and they will describe it to you as well, like their right side was slow, stiff, and they had a lot of difficulty when they would bathe or put soap, that one side would move more freely while the other side wouldn't, and they would keep their right arm close to their body as they walked. They wouldn't swing it as much. They'll also describe things like their shuffling, taking short steps, slow walking, their handwriting, instead of being scratchy like you saw with the previous patient with essential tremor, their handwriting with Parkinson's is a very small handwriting. They start off big. By the time they finish the sentence, It's so tiny it almost looks like a scribble. They lose their sense of smell, and very rarely do they have a family history. This is how typically we pick up on whether this is Parkinson's disease or essential tremor. If you're still kind of suspicious that could this person also have an element of Parkinson's on top of his essential tremor, there's a particular scan called the DAT scan, which can be done to completely pick up on radiological microscopic features of Parkinson's disease. If that scan is positive for poor uptake, is what we call it, the poor uptake of the dye, then that's consistent with Parkinson's and similar disorders and not essential tremor. Some of the questions we ask, and you need to ask yourself as well, is what all does this affect? Is it affecting my ability to eat or drink, pull from a cup, eating soup, eating peas, for example? A lot of us with tremor stop doing those things. We start to drink with a straw or with a lid. We stop using forks to eat peas, or we bring our mouth real close to the soup bowl to slurp our soup. Grooming, difficult to put on makeup, to shave, putting on toothpaste on your toothbrush. Hobbies which involve fine skills of dexterity. You stop tinkering with small things, you stop doing crocheting, sewing, things like that. Is it affecting their ability to write, to speak or sing? Is this affecting their work? And finally, is this a form of social embarrassment because of which they don't get out as often? Let's find out what happened to this patient.
Then I went.
Well, there you go. A lot of times we've seen it both in the literature and people describing it as a benign familial or benign essential tremor. As you can see from what she just told us, it's not very benign, is it? I mean, it's affecting her ability to be part of a social gathering. It's affecting her ability to hold jobs, not just one job. I mean, think about it. She started off as a nurse and went down to as much as even trying to be a waitress, and even that was not possible. So this can be a very debilitating disease and very far from being benign. So what options do we have in treatment? So when you have tremors earlier on, when it's mild, we can do some simple steps. Like for example, minimize your caffeinated products. Anything which is caffeinated, minimize it, or go to decaf. That'll help you quite a bit in terms of reducing your tremors. Alcohol, well, that's a little bit more tricky because it can improve your tremors temporarily. But the problem is, a lot of folks will have a rebound worsening of your tremors in the next several hours after it has improved the tremors, or the very next day, you're worse off on your tremors. So, while it can improve it temporarily, like perhaps you're in a social gathering, you have a glass of wine, it can help you. But just remember that you may have a rebound in the next several hours or so. Always drink about no drink and driving is a no-no. Please discuss alcohol use with your own physician before you go ahead and use that as a way of treating your tremors. What about medications? There are a lot of offending medications we talked about a couple of slides ago. The possibilities of stopping it or even changing it to a more cleaner drug which has less impact on tremors. Occupational therapy. These are therapists who work with your arms, and they can help you quite a bit with strengthening in your arms, with offering adaptive devices, telling you about adaptive devices. In fact, if you look up in the IETF webpage, there's a whole section on adaptive devices that you can use as part of your work or part of your day-to-day activities, like larger keyboards, weighted spoons, weighted gloves. All of these things can help dampen your tremor. If you have a high level of stress, remember stress, fatigue, anxiety, excitement will always amplify or worsen the tremor temporarily. So if you're very prone to stress and that amplifies your tremor, in turn, seeking help from a counselor who will help you with behavioral or biofeedback therapy is a very good way in trying to tackle the stress and then indirectly the tremor. What about medications? There are two major classes. One is called beta blockers. This is a class of medications used to reduce hypertension or high blood pressure. Among the beta blockers, the one marked in red, propranolol, or in its trade name, Inderol, has probably the best data and works quite well. Other drugs within that class include atenolol and nadolol. Among seizure medications, these are medications used to control seizures or epilepsy. Primidone is the one that stands out the best. So propranolol and primidone are probably going to be your first-line medications that we try, after which we can try other drugs, especially other seizure medications like topiramate or Topamax, Neurontin, clonazepam. These are typically the different kinds of medications that your neurologist or your physician will try on. Remember, about 70%, a majority of patients will respond to medications, and a lot of these medications can be mixed and matched in combination together to get better efficacy. In the early days, these medications can reduce or improve tremor by up to 50 to 80%. And as the disease progresses, the tremor just keeps getting worse. Even after you max out your medication, the tremor starts to get resistant, and the effect of medications on tremor can be as low as 30% improvement. There are other modalities as well that we can try for tremors. Botulinum toxin or Botox, we're more familiar with that, used in cosmetics, can be used in tremors strategically. Now, botulinum toxin paralyzes or weakens muscles when we inject this particular toxin into that muscle, which is why you reduce the wrinkling around your eyes when you get it injected for cosmetic purposes. In tremor, what we're trying to do is we're preferentially injecting the muscles which induce the tremor in that particular body part, and thereby preferentially weakening those bad muscles, whereby now the good muscles can keep the joint steady without the tremor coming out. Now, this is very good in theory, but the problem is many times if the tremor is very excessive, the dosage which is required to dampen the tremor is quite high. And meaning if it's a high enough dose, you end up excessively weakening those muscles. Meaning the tremor will go away, but it'll be at the cost of weakness in that particular joint. So if you get shots in your forearm to reduce the tremor in your wrist or in your hand, many times it is at the cost of weakness, which you will perceive as, for example, when you try to lift heavy groceries, etc., you might feel like you don't have the full strength to lift it all the way up. Now, these can be used strategically in your forearm, for your head tremors, and even for your vocal or your voice tremors.
Now, what all medications have you tried?
I've tried just about it.
The Primidone, you were on a pretty hefty dose.
I was.
You were on about 250 milligrams 3 times a day.
Yeah.
And it stopped working. Was it working initially for you?
Yeah.
And then over the years, it just gradually lost its effect?
Yeah.
Okay. And on the present combination of Thermomax and Primidone, there are limited by side effects themselves, correct?
Yeah.
What's wrong?
I didn't have the side effects of I
So it's your fatigue body. And with the Thermomax, what will you reach? So you're never going to go too high. It helps. How was the issue? Was there any weakness you perceived with the injections? Or that was
Well, there you go. So you can see that many of the medical options that we have come with their own issues. So, for example, the beta blockers, Inderal or propranolol, they can cause slowness of your heart rate, meaning that in turn manifests as fatigue or your inability to exercise excessively. They can drop your blood pressures and you get lightheaded. The primidone can make you feel like you're drunk, unsteady, sedated. Different seizure medications can have different effects on your sleep and your thinking and your memory. And as you just heard with the Botox, the weakness, even though it was quite effective. So when do we start to consider more advanced surgical options for the treatment of essential tremors? One, when the medications stop working, meaning your tremors have become refractory to medications. Or number two, the medications work well, but the side effects are very severe that it's not worthwhile taking the medications. Number three, your tremors are impeding on your simple activities of daily living, meaning it's impeding your ability to just feed yourself, groom, take a bath, go out, bring back your paper and read it. These simple things are all impacted. And number four, the tremors start to affect your work. Okay, so these are the times when you need to consider beyond the typical medications or even injections, what surgical options that are available. From a surgical standpoint, the target in the brain is the thalamus, a small structure within the middle part of the brain, which we can either destroy a small portion of or use electricity and stimulate, and in turn we get a benefit on tremors. The process of destroying a very tiny portion of the brain or a nerve circuitry within the brain is called ablation. You can see written right there. The benefit is that it's very immediate, that when you destroy those nerve circuitries in the thalamus, almost immediately you start to see a difference on your tremor. The effect is permanent because you're pretty much taking out those nerve cells from the equation. And so the tremor benefit is permanent. If you induce any side effects because you took out nerve tissue which was adjacent to it, which shouldn't have been taken out, the side effect which it creates is also permanent. So you see the issue with it is that any effect, both beneficial or side effects, is permanent when you destroy tissue. Stimulation. Here you use electricity using hardware, like you put wires into the brain to stimulate a particular region in the thalamus. In this particular situation, we're just stimulating the circuitry to do what we want and reduce the tremor. The downside is it is not permanent. Every time the electricity switches off, for whatever reason, let's say you have to switch off your pacemaker or the battery dies, the effect is lost and you have to either change out your pacemaker with a new battery or crank up the electricity some more. Let's look at a little bit more detail on the stimulation form of the surgical intervention. We call this deep brain stimulation or DBS. In this process, what we're doing is we're implanting a pacemaker for the brain. It looks like a small battery which is implanted under your chest muscles or sometimes further down along your tummy or abdomen. And the wiring from that battery is tracked under the skin from the chest along the side and back of your neck, going up all the way along the scalp. Once it reaches the top part of your scalp, two small holes are made in your skull through which wires are inserted strategically into the location of where we're trying to stimulate. This whole wiring scheme, which you see right here depicted in this cartoon, you can see the small lines going into the middle part of the brain and the wires conducting electricity from the battery to either side of the brain. As part of getting DBS, initially we need to get an MRI of the brain. And this is a planning MRI done so that we can plan out the trajectory in which we can insert the wires. The surgery can be done in 1 or 2 stages depending again on the hospital or the institution. The first stage is where we implant the electrodes within the brain itself. Typically in this situation, the patient is awake, lying on the table as the electrodes are inserted. Remember, the brain has no pain nerves, so you don't feel it as this is going in. The reason why we want you awake for this procedure typically is because once the electrode is completely set and in the right position, they actually test it by giving electricity through those wiring. And we test and see if the tremors disappear in your hand. Is there any side effects that you're perceiving? And accordingly readjust and reposition the wiring. Once the wiring is set, we close off the 2 holes and then we get on to the second stage where under general anesthesia, the pacemaker and the rest of the wiring from the chest along the back of your neck all the way up to the scalp is implanted. Now remember, the effects are persistent only as long as the electricity is given, meaning if you switch off the pacemaker, it's like you did not have the device inserted into you. That's how it will perceive to the patient. Initially, the programming is done about a month after the DBS is inserted, and then for every couple of weeks till we get to the right programming. And once they're stabilized, follow-ups with the physician is every 6 months to a year to keep tabs on the DBS. The patient is also given his own mini programmer, which he can use for minor self-adjustments like cranking up, cranking down the electricity, changing small programs within it, even switching off and switching on if he needs to. The battery typically lasts about 5 to 6 years with our present technology. We're getting better at it, probably getting into a 15 to 25-year life with the next editions. And it is a more simple procedure to replace it when it starts to run out in about 5 to 6 years. It's day surgery. What about complications about DBS? In most good institutions where this is done quite a bit, it ranges around 1 to 3%. Among this 1 to 3%, the big chunk of complications come from infections. And infections come around the places where this was inserted, meaning along the suture lines where typically you see the infection. So to prevent this, your surgeon will be giving you antibiotics before and after the procedure. They'll be giving you antibacterial soaps to use just to prevent any infection along the suture lines. The big thing as to why we fixate on infections is that we do not want that infection to seep into the hardware, because unlike our body, which has an immune system, the hardware does not have an immune system. So if the bacteria latches on to the wiring, then we have to pull it out because it becomes a permanent breeding ground for bacteria. And that's no good when you have hardware sitting inside your brain. So in the small chance that you get an infection on the hardware itself, it is pulled out for that side. We let the brain heal and we reinsert it back again. Other low risk complications, low risk in the terms of percentages, is bleeding and strokes, but it's high impact. Even though the risk of getting it is low, bleeding or having a stroke while the electrode is placed into the brain. What about complications of stimulation when you give the electricity? The most common pattern which we see is a transient or temporary tingling like sensation along the skin or the face on the side which you're trying to stimulate. This comes on and then it goes away very quickly in a few seconds. You can also have persistent problems like persistent tingling along the face or skin of your arm or leg. You can have slurred speech or balance issues. The advantage of stimulation in this regard is that any complications which you sustain with electricity, you can readjust the electric parameters so that you have very minimal to none in terms of side effects. In terms of improvement, remember, these are patients typically who have failed or whose effect with medications have gone down. These are patients who typically get the DBS. And in them, tremor improvement ranges around 70 to 90%. This is based on various published literature. We have long-term data as well on patients showing that there's been a persistent benefit. As far as 13 years has been reported. Remember, however, that surgery does not change the natural progression of the disease in any manner. So you're still going to progress over the years, even with the device in you. So we do need to tweak that electricity from time to time. It is a reversible option, which means your options for future therapies are still preserved. This is a patient with her DBS switched off. You can see her tremor coming back. And it takes a lot of effort for her to write in a legible manner. You can see the tremulousness as she starts to write.
It is a sunny day in Oklahoma City.
Well, how come I'm so sick?
Well, I switched off your DBS.
When you said it, no.
My residents are going to hear this. You
What?
start here in the middle, and you work your way out.
As you can see, not many of them appreciate their DBS being turned off because it's a substantial benefit which they usually get.
Keep going. Okay.
They're pretty tremulous when they're switched off, and this is switched on. You can see no tremor, a more clean handwriting with no tremor as she holds the pen.
What's the difference? Now that it's switched on.
Rather different.
It's less tight in your hands. You're not
Yeah,
holding the pen as hard as you need to be.
right.
Anything else? The tremor is less, obviously, I can see that.
Was just easier to make my letters. Like on this U, I would have a hard time.
Okay. Draw me that spiral.
I go this way, right?
Either way is fine.
So you can see how shaky that spiral was last time, and almost a clean spiral with occasional interruptions. All right, so switching gears from stimulation form of surgical interventions to ablative forms of surgical interventions. Initially, we used to have what we call radiofrequency ablation thalamotomies, whereby you use electricity to generate heat and destroy a certain part of the thalamus. The effects were very immediate. On the table itself, you would know the difference. However, there are a high rate of side effects like persistent slurred speech, balance issues, and for each side when you did it, you would get a component of slurred speech and balance issues. So if you did both sides, you compound that problem. So we never used to do this for both sides because really the patients would start to get really off balanced and have pretty bad speech. Then came more non-invasive methods like gamma knife thalamotomy. Here what we're doing is we're shooting radiation beams strategically into a very small part of the thalamus, and we're causing ablation or destruction of a small section of the thalamus. The side effects are less compared to radiofrequency ablation just because it's much more precise. However, the one issue is that it takes time for its effects to manifest, meaning when you radiate nerve cells, they don't die immediately. It takes several weeks for them to gradually die out. So once you get the procedure, you wouldn't know immediately what its impact was on you. You would have to wait weeks to know how your tremor is subsiding, meaning any beneficial effects or any side effects from lesioning regions of the thalamus which you didn't want to. So benefits or side effects will take weeks to months to manifest. The same issue with radiofrequency ablation also applies in terms of the speech and the balance issue, so we tried not to do both sides, and only one side is recommended. Then the latest form of ablation, which was approved in 2016, the X-ablate neuro, which is the ultrasound ablation. Again, this too is non-invasive. Here we're using MRIs to guide us in shooting focused ultrasound energy into a very small section of the thalamus, and you gradually increment the energy till enough lesion occurs and the patient achieves reduction of tremor while on the table itself. The advantage of this over gamma knife is that it's a very immediate effect. You know the results immediately, but the same issues of side effects apply, meaning if the lesion size is a little too big, you get speech problems or balance issues, and you compound that problem if you did it on both sides. So even with this ultrasound procedure, only one side is recommended. Bottom line with surgical treatments is that you want to pick an institution or a hospital system which has had a high volume of DBS surgery or ablative surgeries, and also concomitantly low complication rates with that high volume. Make sure you're seeing a specialist like a movement disorder doc who's knowledgeable about both the DBS programming as well as injection procedures before you get into it. Questions you want to ask your neurologist or your surgeon is, how many procedures have you guys done? What have been the complication rates? What have been the success rates? Can you get me in touch with some of the patients you've had this procedure done with? This way I can ask them about how things have been in their particular scenario. Is this covered under my insurance plan with your hospital? What kind of follow-ups do you have? Will you be seeing me within the hospital or only on the clinic side after the procedure? These are the several questions you want to ask in regards to surgical treatments. As regards to insurance coverage for surgical procedures, FDA approval was received for DBS in '97. Medicare has policies in almost all 50 states. Most of it will cover without any issues. Most commercial insurances also cover the device without problem. What about new things? I won't focus too much on this today, because today it was a basic lecture with focus on existing treatments. The research has been in looking at what are the mechanisms at play in the formation of essential tremor. They're looking at refining existing modalities like deep brain stimulation to make it even better, more longer in terms of battery life. New therapeutic agents like medicines like octanoic acid. Finally, non-invasive measures like cortical stimulation or transcranial magnetic stimulation to reduce tremors. This is going to be my last slide right here. I'm just leaving some references on this page for you to look up if you're interested in deep brain stimulation. And the Medtronic website, I've put that up. Also the IETF, the International Essential Tremor Foundation website with www.essentialtremor.org, or their toll-free number. It's a very useful website with the gist of what essential tremor is and what all different options are available, what support groups are available at your local site. I would encourage everybody to join a local support group involved in essential tremor, because this helps you engage with the physicians who come out and speak about this. It helps you be more knowledgeable about the new advanced therapeutic options available, and supporting your other folks who have similar diseases. Many times patients learn from each other how to cope with the disease more effectively. All right, well, thank you so much. I'm going to take questions now. I'm going to look through the different questions asked, and I will answer them as best as I can. First off, there was no way for the PowerPoint sound as well as my volume to occur simultaneously. So I think that's a glitch in the system. So sorry about that, guys. All right. Let's see. Somebody asked me about the ultrasound guided MRI guided surgery. I hope he's going to talk about it. Yes, we did. I'm waiting for more questions. Let's give it another 5-10 minutes. So a question on, does insurance cover focused ultrasounds? This is a brand new procedure with a lot of procedures which come out in the first and second year of launch. Many times than not, many insurances do not cover this procedure, okay? Or we have to make a case that, this person cannot get other advanced procedures. For example, why is this person not a DBS candidate or deep brain stimulation candidate? We make a case for that, or we say that the patient is not interested in an invasive procedure, and we try to get an overruling from the insurance. But that's been our issue with focused ultrasound, at least for now. One other thing you got to understand also is that with focused ultrasound, the same recommendation of doing it only for one side applies. Because remember, once you damage a part of your brain, however small it is, if you get side effects from it, it's permanent. You compound that problem if you did the same thing for the other side. So if you got a little bit of speech problem or a balance problem, you compound the same thing for the other side as well. And once it's done, you cannot revert it. All right. Is DAT scan a conclusive diagnosis tool? From the standpoint, so if your neurologist is worried about is this Parkinson's disease or is this essential tremor, then yes, because what DAT scan does is that the dye which they give for this particular scan goes and connects to dopamine transporters, which are on the nerves which shoot out dopamine. And this is what is damaged in Parkinson's disease. So if it's a normal person without Parkinson's disease, or he has just another tremor disorder like essential tremor, he will have intact dopamine neurons or nerves, meaning all the dye which is given to the patient will go and connect on both sides quite well, and you get a normal scan. If you had Parkinson's disease, or even the beginnings of Parkinson's disease, you've almost lost 50 to 60% of your dopamine nerves. So meaning when you give the dye, you're going to get at least 50% reduced uptake of the dye for one side or the other, especially the side which corresponds to the arm which is tremoring. So it is pretty conclusive to either rule in or rule out Parkinson's disease. Why does DBS not ruin other chances in the future? I kind of mentioned that. Well, for one thing, the electrode which is inserted is very, very tiny. So if you actually pulled it out, it's like as if you never had anything inserted in your brain in the first place. It's not like it's crossing a lesion on the size of an ablative procedure. So, for example, if future therapies or modalities come into play, like, for example, we don't have any of those things right now, but let's say it does. For example, nerve restorative therapy by inserting stem cells, etc. These are all still possible by pulling out the electrode or the wiring. Many of the more advanced, newer forms of medications can be used simultaneously with DBS or with ablative procedures. The difference between ablative procedures and DBS is that once you ablate or lesion, that whole section of the brain is gone. There is no reverting that process. And that is why we say DBS is reversible, and if you have any advanced future therapeutic options which involve an invasive process like you're inserting something into the brain, it's easily, you can pull out the wiring of the DBS and continue with your new invasive procedure. Then, let's see. Some folks have asked, they've tried medications like propranolol. They're having an issue with skin dryness around the nose and skin redness. Again, remember, this is not a common side effect, but if you're getting immediate side effects right after starting a new medication, always touch base with your physician to make sure you have an alternative drug to try. And as I pointed out earlier in our slides, primidone, Topamax, gabapentin, these are all other drugs which we can try. All right. Then let's see. Anyone here had DBS, please contact. Let's see. some patients, I think some have had these episodes of lethargy or fatigue every afternoon, lasting about 4 hours just in the afternoon. And it almost feels like a mild compression in the head. And most of the neurologists which the patient had consulted didn't seem to know what was going on and the experience with this. Well, for one thing, just the way this is occurring, especially in the afternoon, I'm going to assume this is happening right after lunch. The typical scenario where you start to have afternoon lethargy or fatigue with a pain which kind of an achy pain which occurs along the back of your head, going along your shoulders, almost like feeling like a coat hanger. That typically is drops in blood pressure. Okay, and you can exacerbate it by standing up. Like if you're sitting down or lying down, you feel better, and you stand up real quick, you can have drops in blood pressure, and you will manifest like this with pain along your neck or your shoulder, with feeling fatigue or lethargy. Typically, that's a drop in blood pressure. The fact that it's happening only at a certain time of the day doesn't really equate to stimulation or DBS. I suspect certain medications at play. The most typical agent which causes this kind of a pattern are beta blockers, like the propranolol. All right. The easiest way to confirm, so again, the follow up on that question, is compression all over the top of the head. The easiest way to confirm if this is the issue where you're dropping your blood pressures is actually with the guidance of your physician, check blood pressure readings both sitting and standing when this is happening. Meaning you take your blood pressure while you're seated, you stand up and you recycle the machine again, get what the readings are. If you see a consistent drop in blood pressure every time this happens, you know that's exactly what's happening, and your physician can guide you from then on. All right. Do you have a high probability of getting Parkinson's if you have ET? No, you don't. There has been some genetic predispositions to getting both essential tremor earlier on and then a form of Parkinson's like disease later on down the road, but that's a small subset. Let's see if there are any more questions. The last question, how long is the transmitter for the DBS? Well, I'm going to assume the question is regarding how long is the actual device which is inserted into your brain. Now, we're talking about a device which is millimeters long, which needs to sit inside the small circuit inside your brain. It is connected by wiring all along to the top of your skull, out through the skull, along under your scalp, along the side of your neck, going all the way down this wiring, all the way to your chest muscle where the pacemaker is implanted. Oh, okay. The question asked is, how small is the device that is put in your chest? So meaning the pacemaker. Well, I would say it is about 2.5 inches wide and about 2 inches lengthwise, so in either direction. Think of it as about a fist size of a small baby. 2.5 inch in width and about 2 inch wide. And it's, I would say, about 1/2 inch thickness, roughly. So for the most part, you will not feel it or you will not see it jutting out from the top of your chest unless you're a very skinny person and you have very little fat padding. The devices are actually very light, so I'm not terribly sure what you saw. The one thing which you may have seen is the actual remote control. The device which we use to communicate with your pacemaker, that's pretty heavy and big. The device which I'm referring to has been in the market for almost 10 years. So I'm not sure what you've seen at OHSU, but these batteries, remember, they get better with time. And so we need smaller and smaller and smaller pacemaker batteries now to charge your system. You don't need a very hefty battery implanted into you. All right. Well, in that case, I'm going to pass it back along to Patrick here real quick and conclude our session.
Okay. Thank you, everyone, for joining us tonight. That's all the time we have for today. I want to say a quick thank you to Dr. K for helping us today and presenting in our first webinar. We apologize for some of the glitches we had with the sound and getting logged in and all those kind of things. Just as a reminder, we will have the webinar posted on the IETF website, hopefully by the end of the week. You all will get an email with a link to the webinar, and feel free to share that webinar with any of your friends and any folks who might find it interesting. We will continue to do these webinars and hopefully get better at them each time we do it. So thank you again for joining us tonight, and thank you for your support of the IETF. And we look forward to seeing you and hearing you at our next webinar.